Good afternoon. Thank you for spending some time. Okay. Thank you for dedicating your time this afternoon to our presentation. How many of you know where Manitowoc, Wisconsin is? Really? I am impressed. Okay, you might be aware that Wisconsin as a state is known for a couple of things. Really good football, most of the time, and beer. And a little metaphor I'm going to give you is talks about our culture and the challenge we had for innovation. Across the street from our hospital, and I'll describe our organization a little bit in a second, was 18 grain silos. It was called a malting plant. 100+ feet high, concrete, and that was representative of the silos we had in our organization. We're a large group practice, multi-specialty, in a relatively small hospital. Unbelievable separations between them culturally. And when we talk about learning organizations, innovation, and maximizing human capital, it's quite a challenge. So today, I'll describe the organization. But what we did in 2005 is Archer Daniels Midland donated those grain silos to us and $700,000 so we can knock them down and make a parking lot out of them. So it's a great metaphor for the work we've been doing as an organization. This is our organization. We are located just north of Milwaukee and south of Green Bay. As an organization, we're very tightly integrated. We're a single corporation, large multi-specialty group practice, as I mentioned before, significant focus on wellness and prevention, relatively small. This is unique for this kind of presentation that you're going to see here today, in that we are a very small organization. S&P considers us a standalone hospital. The AHA has developed a white paper last year that I don't know how many of you saw it in the fall. It's called the Hospitals and Care Systems of the Future. And it described a first curve and second curve environment, which is very important for us because we are organizing ourselves around that. Of course, we started doing that about 10 years ago. It's just this happens to fit our direction very nicely. But I'm only going to talk about it for a minute or two. First, volume-based curve is on the left. That's fee-for-service, inpatient orientation. And, of course, in most areas of the country, that still dominates the reimbursement system. And it certainly dominates the hospital delivery system. I was at a variety of American Hospital Association meetings, and all the measures and indicators and quality measures are still inpatient-focused. Our organization started quite a while moving towards the second curve. And this is how far along we feel, in our delivery system redesign. And we're going to tie this to the human capital because the challenge for our organization, along with those silos, is that the average tenure in our organization is 14 years. The average leader tenure is 18. I'm 11, which means I'm about 80-something% towards the halfway mark of the average tenure. Towards the average tenure. So that's a challenge for maximizing capital. The infrastructure we designed, we were very advanced in IT. Culturally, Laura's done an incredible job working with us on culture shaping. Collaboration, we actually have medical homes with long-term care facilities. We actually have our docs embedded in long-term cares. Unfortunately, we're still solidly in the first curve in terms of reimbursement. Our philosophy is to deliver the right care. Evidence-based medicine is very much dominating what we do and how we do it. The right setting, which means the lowest cost for us and the highest value, and the right outcome. And this is significant for us because our definition of outcome, because we live with the people we serve, they literally are our neighbors, we're looking out for their well-being way beyond just the healthcare episode that we've given them. From what I've said so far, our challenge is to maximize the human capital and the leadership because we can't bring new people in fast enough to make this first curve to second curve transformation. We have to do it from within, be proactive in how we're disrupting our culture and our processes. What we've delivered so far to reflect this is as follows. Over the last decade, we've actually been able to reduce the inpatient utilization in our community by 43%. There's 43% fewer patients being admitted from our service area than there were 10 years ago. We have not really cranked up the outpatient volume, much to the chagrin of my CFO, to the tune of about 8%. And we've rate adjusted the total charges experienced by hospitalization from our organization, actually with about a fifth of our organization has decreased, an 18% decrease, excuse me. What's happened for the overall market? What does that mean? Overall hospital utilization has declined inpatient, outpatient combined by about 25%, with an improvement in population health, which I'll show you in a second. This is what the organization looked like and why Laura's efforts and mine are so coordinated. Our organization in 2001 had about 90 patients on any given day. We had about 35 employed physicians, a relatively small number of independent physicians. We had 10 senior leaders with their own silos, very intensely guarded. And we had a mission statement that said we'll provide services to all who seek our care, a very typical hospital-oriented mission statement. And we were known about 10 miles north and south in terms of our reputation. Today, a typical day, we'll have 30, 35 patients in the hospital. We have a 90 provider multi-specialty group practice, as I mentioned before. 10 senior leaders are now 5. And the key thing is we've leveraged the leadership to make that happen in a much more effective way. Our mission statement was converted to help individuals and communities achieve healthier lives in 2008, well in advance of the Affordable Care Act, which focuses on population health. So that has indeed been a great way of reframing our efforts, very much in context of what the federal government would like us to do. And finally, we're somewhat known, actually, for what we're doing here in Little Manitowoc, Wisconsin, which is why it was so cool that you guys have actually heard of it. This is what's happened with the major 4 disease entities in our community. This is not just our work. There is another hospital in town, Aurora Healthcare, and also some variety of public health activities. But this is led by our activity. So far, we've seen about a 16% decline in mortality over that same span of time. And from a population health perspective, the Robert Wood Johnson and the University of Wisconsin Population Health Institute have documented that we have improved the clinical care aspect of population health by about 42% over the last 3 years, to the point where we're 18 out of the 72 counties in Wisconsin, which we think is pretty cool, particularly since the other 3 indicators of population health, which we don't have time to get into, although Andy mentioned some of them in his comments, we don't do so well. The malting plant has left a rich legacy in our community. So this is what I mean. At this very moment on 21st Street in Franklin in Manitowoc, Wisconsin, you can see these 2 billboards right next to each other. On the right is It Wasn't Indigestion. That's an advertisement for our Heart and Vascular Center, which is pretty cool. We've actually had people say, I went to your place because I realized that chest pain might be something, and it wasn't indigestion. And on the left is McDonald's. If you really have a slow moment, actually go on friedrate.com, which is actually a website. And you go there and you'll see the French fries on the left, and you can match them with different kinds of Frosties. It's very cool. Okay. It's great for the first curve business, but we're trying to do population health and second curve. The reform roadmap, this document is actually on the AHA's Great Board's website. And to maximize our leadership, our human capital, what we're doing is trying to focus on how to give people permission to change and make it safe to change. The first way we've done this through Lean Six Sigma. I don't think there's a healthcare organization in the country that's not doing some version of that. We've been at it about 7 years now, and we found it to be an incredibly useful tool. We actually have an innovation process that focuses on reinventing services on a rotating three-year schedule, and I'll talk about the results after Laura in that regard. And we actually spend a lot of time working with our community on how to fundamentally change the organization in a proactive way. The improvement focuses on staff and physicians. We've successfully engaged 80% of the organization in one activity or another. The innovation process and SPUR, which is Strategic Program and Unit Review, has engaged leadership. And actually, the strategic transformation is wonderful in engaging the community. We actually have outside eyes join us in looking at how we're configured as an organization to help us be introspective and reflective. Key things in this reform compass is to hardwire improvement and innovation. We actually have one now pool of change support specialists. Our leaders need to focus on strategic activities, not just the walls in front of them, and also importantly integrate physician leadership, which is always a challenge. We have a phrase that we use, which is called, we are what we tolerate and we become what we reward. Because we find all these competencies that Laura works on, which are wonderful, and she has relied on the NCHL for some of them. People get confused. This is pretty straightforward, and it helps in making it real. Here are strategies. I'll just mention them quickly, but we're working on redesigning the care system, working on exceptional experience, which is incredibly hard because the culture of our caregivers is so focused on their world, what they want to do and how they want to do it, and the ideal culture. And one of our employees came up with a way of phrasing it, and she said, hey, it's just redesigning care around an exceptional experience by way of an ideal culture. And that way it's simple enough that even I can remember it. So With all that, it sounded very linear. It's not. So there's a ladder of success, and Laura's about to share it with you.
Thank you, Mark. And of course, it does take a lot of assembly to build a ladder of success. We knew that back in 2009 when we saw a lot of changes coming forward for healthcare reform. We understood that we needed to focus on our workforce to help them be more adaptable and open to change to be able to be successful in our future. So we decided that our #1 strategy that year was going to be workforce and organizational culture, and it was our strategy for the next 3 years. We began that work by hiring a firm out of Michigan, Human Synergistics, to complete a cultural assessment for us. And the assessment was to define our current culture as well as help us define our ideal state or where we wanted to go to be successful in the future. We gave the assessment to all of our employees, our employed staff, physicians, leaders, board members, all participated. We had a great response, about 70%. And it defined it defined our current culture as very conventional, dependent, approval-oriented. And we were told by the agency that that's very typical for a Christian healthcare organization. Our ideal future state then was defined as humanistic, encouraging, self-actualizing, and achievement-oriented. This then became our 2 curves, as Mark talked about earlier, for healthcare reform. These are our organizational development curves. And as you can see, obviously there's a huge gap in between. So we started working on a number of different initiatives, and we understood that leadership development really needed to be a key because we needed our leaders to role model the ideal culture. So we developed a variety of different ways to do that. One thing we created was what we call Leadership Institute. This is a series of educational modules focused on our new competencies, and I'll talk about them in a little bit, taught by our senior leaders. We then invited 20 of our above and beyond leaders to participate in the program. Once the program was completed, they all participated in projects as well. And that's been very successful, and we've continued that. We also created a leadership assessment and ranking tool that I'll talk more about in a little bit. We continue to encourage and promote leadership development, self-development, and employee development. We're very much focusing on being a learning organization, getting people to learn, develop, and grow, and having leaders work with staff on doing the same thing. We've also done that with providers. In fact, we've chosen 3 physicians to move into a leadership role on a part-time basis and develop pretty extensive leadership development for them as well. We hire annually administrative fellows and interns from renowned programs throughout the United States to bring in some outside eyes. As Mark said, the tenure on our leadership group is very long and turnover is very minimal. So we want to bring in outside eyes to give us new creative ideas. We do that also by developing learning partnerships with a variety of different organizations. Very many different businesses that lead differently to help us learn to do that as well, and then we work with them on learning there also. One of the things I talked about was developing new competencies. Mark mentioned I'm pleased to share with you that we did adopt competencies from a very prestigious, well-known organization, a few brownie points there, from NCHL. And we took these competencies and we developed an accountability review. How many of you do performance appraisals with your people? Probably pretty consistent, yes. We call ours an accountability review to remind our leaders of the importance of being accountable, and then also a review because it's a rear view mirror look on the work that they've done in the last year. So that was one tool. We also realized that in order to get from our first curve to our second curve, we needed to lead differently. So we wanted a tool to help us determine how our leaders, what ability our leaders would have to lead differently. So we created an assessment, and it's a weighted tool. 30% of the assessment is able to, or a leader's competency to lead, willing to, our leader's desire to lead. The most important part of the assessment is 50%, and the components there are courage to, which is internal fortitude to lead, or as Mark likes to say, who would we give the ball to in the 4th quarter of the Super Bowl? Aaron Rodgers types, of course. And then also culture-shaping congruity.
There's some Bears fans here.
Oh, well, that's okay. I'm sure they don't mind. And culture shaping congruity is our leaders' ability to fit in the current culture while transforming to the ideal state. And then last 20% was promotability, and that's just advancement potential. So all of our leaders were scored on a scale of 1 to 5, with 5 being the highest in these different areas. And this tool became a very robust, user-friendly tool that we update on an annual basis. And it really does help us determine whether our leaders are going to be able to help us get to the second curve in the future. The other item that we do is we take both the assessment and our accountability review scores and we compare them. Let me share with you here first of all, the assessment scores. And as you can imagine, the assessment scores and the PAR scores for our high potential leaders are both going to be high on both tools. As you move to the middle, it levels off a little bit. But interestingly, we found that as we moved to the low with our assessment scores, our leaders who scored low on the assessment, many of them scored high on the accountability review, which means that they obviously are capable of doing the work, the daily operations, and lead as we have in the past, but may not be able to help us move to the future. So this tool has become, both of these tools are very useful for us. Obviously, we we challenge and reward our high people, coach and develop our middle people, and then make changes as appropriate with the low performers, either redeployment or inviting those people to leave as necessary. So with that, I will turn it back to Mark to have him share with you some of our results of the work we've done.
Thank you, Laura. In terms of the outside eyes we've had help us through this transformation, we also used a lot of coaching as part of this, because one of the things that's an integral part of our change process is being introspective with who you are today. JCD advisors, Janet I see is here in the room, is one of the groups that helped us work along through this process. And when I saw this score, I was particularly impressed with it, because I, like many other organizational leaders, thought that we were developing leaders, and that based on the competencies of organizations like the NCL that we had borrowed, that they're not going to be adequate. We're going to need to do something different. At least that's our opinion, and so we were working accordingly. The SPUR process I mentioned is Strategic Program and Unit Review. Basically, what this is, for those of you who remember zero-based budgeting, it's something like that, only from a touchy-feely point of view. We do the numbers and the metrics, of course, but it's also, are we any good at this particular service? We actually have about 90 programs, so everything from smoking cessation to ICU. And so we go through these in a way that's very, very objective, systematized, consistent, and decision-oriented. We make an intentional decision to either grow or improve. We used to say maintain. We don't say that anymore, but for data reporting, I had to include it, or reposition. We're a Catholic organization, and I mentioned the touchy-feely part. We're not allowed to really talk about closing, selling, merging. That's kind of a negative kind of connotation, so we call it reposition. What was cool about this in our first iteration of this is that we actually repositioned more than a fifth of the organization, starting in 2009. So that's a big deal for any culture to go through that, particularly when you're doing it to yourself. There's no burning platform. We're making good money throughout this period. If we get time in the question, I can talk about margin and all that. But we felt that we needed to do this. Green dollar-wise, we've exacted about $4.3 million in improvements. Innovation, a separate process, is $2.6 million. So we've improved the operation in hard green dollars about $7 million over that span of time. Now, most of the time when you do like this repositioning stuff, that's injurious to your culture. People get a little nervous about it, feel like things are outside of their control, that sort of thing. And remember, Laura said our #1 strategy was organizational culture. So the next slide here, we'll talk about how we did during that same span of time. Again, we started this repositioning stuff in 2009, and in 2008 we had done a baseline. This is what we call a pride survey. So we took a few of the questions. Overall, every category showed significant growth, and we also got about 70% turnout on this. I'm proud to work for the organization. We had 71%. Sadly, we'd like that to be like 100, but that's actually not bad. Went up to 87%, even though we had repositioned a fifth of the organization during that span of time, for a change of about 23%. And then the next question is, I would recommend. 76% grew to 87% for a nice change there. This was cool because this is in the recession and healthcare reform being talked about. I feel a part of the organization, and I'm excited about its future. 48% pretty typical when you're going through tough times. 73% engagement for a 51% improvement. Again, using that we're maximizing the individuals through the change processes to help redesign and shape the organization so they're feeling part of the action. And then finally, the leadership team welcomes ideas. This was really sad for me to see that only 42% of the organization felt that way, but glad that 65%, more than 2/3, feel that way now for a rather impressive, at least to us, change process. The physician scores, so you have those at the end if you're interested in those, were actually even better than these. We had the part about, I'm part of HFM and excited about its future, they actually scored about 88%. Now only half of them fill out the survey, but for docs, half filling out the survey is pretty darn good. This is our requisite brag slide, so we put it in here. The key one here is up in the national recognition where we talk about the New North, which is an 18-county economic development region that I'm part of, we're part of. The Excellence in the Workplace, we're the first healthcare award winner. And the Chamber thought we were the Business of the Year. Oddly enough, we were nominated both in the Business of the Year and the Nonprofit of the Year. I'm not sure what that means, but that's how it was, et cetera. So. Success factors in this, we have a reform roadmap. It's given us a point of orientation. It's given us a way to explain pretty simply what we're trying to accomplish, and people get that for the most part. We've been successful in using it to get our governance and our sponsors on board. We are a Catholic organization. My most frequent customers sometimes, and most often critics, are 350 women religious who live about 5 miles from our organization. They actually understand some of the terms we're using here. Leadership development is huge because we actually have about a 2%, I think, leadership turnover. So we're using the fellows, interns, outside eyes like Janet and others as a way of giving ideas and processes, ways to overcome our corporate immune reaction and help move our culture forward. Culture shaping, we're very intentional about that. So every decision we make has that in context, and we've engaged pretty much everyone at all levels. Most can move to second curve, but we'll probably lose about 1/3 of our leaders at some point in the next 4 or 5 years. And that's life, that's okay. Barriers, ideal transitions between the curves is impossible. It is a very nonlinear, messy Hobbesian kind of process. Organizational planning and execution risk is increasingly high at the time you need to have certainty and a steady hand at the most. A highly competent first curve, we've hit this a couple times, workforce is not going to be what you need as your A team in the second. And unfortunately, if you're not intentional about that, you'll get caught thinking that, and it's a problem. And maintaining the organizational commitment behind the why of our service, part of our brand and part of our organizational efforts every day. So with that, we open it up for questions. We've got 2 minutes and 18 seconds, I thought. I'm sorry. Yes?
I'm curious if, based on your results, you've been able to negotiate better rates with your payers.
Yes. We were able to, well, let's put it this way. We were able to get a contract with a payer who had been unable to sell in our market for 6 years. They finally met our terms because they really wanted to be part of the, and it's a big national player. And the efforts we've made have been able to allow us to pretty much hold the line on significant discounts. Wisconsin's a wonderful state from a provider point of view in a lot of ways, from a managed care. So what we haven't been able to do is get anyone to talk to us about pay for performance and results. We're small enough, we're a rounding area for the big players, so that's frustrating because we're ready to rock in that world. Yeah.
You showed the increase in your employee and physician satisfaction. How about the patient experience? What changed in that?
I had a slide for a different presentation, but basically for value-based purchasing, I could just throw that to you. It's improved. We would actually get a bonus right now, if I can put it that way, based on our satisfaction, our quality. So it's not great, but part of that's, remember the small town thing? We're all these patients know, and we've been pretty good for a long time. You know, people from Chicago on the way to Door County, right? Anybody do that around here? If they have a problem, they stop at our place. We get rave letters from these people. Compared to the delivery system that you're experiencing here, it's incredible. But I had a guy complain to me bitterly about the turnaround time in the ER. He mashed his thumb, had x-rays, got triage, got splinted, got sent out, and he was horribly upset about our turnaround time. He just yelled at me for 15 minutes. And I asked him how long he was in our ER. How turnaround time? An hour. I looked at him and I said, that's world-class turnaround. But he wasn't a happy camper. So I go a little zen on it a little bit, but we're good enough for Medicare. 17 seconds. Okay, thank you very much for your attention. I appreciate it.